Lesson 2 of this program deals with inflammation, which is probably one of the most important processes you will study in your professional career. Almost all of the patients that you will see have some type of inflammatory process going on within their oral cavity as you examine them. Better than 90% of the adult population have inflammatory lesions of the gingiva, as well as many of the children. Inflammation itself is probably not pathologic, except in rare instances, but is rather a physiologic process to a pathologic situation. Inflammation can simply be defined as a local reactive change in tissues following injury or irritation. The injury or irritation is of course pathologic, but the inflammatory process is beneficial to the individual. Inflammation is a dynamic process. It is continually evolving succession of events over a period of time, and it can only occur in viable tissue. Please note that inflammation is not infection. Infection means the presence of microbiologic agents, and while these frequently are the cause of the inflammatory reaction, there are totally sterile injuries causing inflammatory reactions. Inflammation is not infection. Some of the major causative agents include chemicals, for example acids, physical agents, for example heat, trauma, allergic reactions, and microbiologic agents. Stop the cassette. Define inflammation and list the causative agents. Here is a schematic drawing of a low-power photomicrograph of human skin. Notice at the top that there is a layer of epithelium which is moderately keratinized, and that there is subcutaneous fibrous connective tissue beneath the epithelium. Notice also the size of the small blood vessels and the relative cellular population. Let us assume that this is your skin and that you have just managed to cut your finger. This is a drawing of a portion of skin showing the lesion resulting from the cut. Thus, an injury has occurred, and the inflammatory reaction must follow. The first thing that occurs following the injury is a transient vasoconstriction. That is, the small blood vessels, mainly the arterioles and capillaries in the field, shrink in size. This transient vasoconstriction is the reason that wounds don't bleed for a few seconds following injury. The transient vasoconstriction is under the control of the nervous system and does not occur in denervated tissue. The vasoconstriction passes within a few seconds to a minute. Following the vasoconstriction, there is dilatation of the small arterioles, capillaries, and venules, which results in a brief increased flow through these vessels, followed by a period of stagnation and stasis of the blood within these vessels. This pooling of blood within these dilated vessels is called hyperemia. The blood from small ruptured vessels flows out into the wound for the formation of the blood clot. As these small vessels increase in size, their permeability increases. That is, they allow fluids to pass through the endothelial lining and out into the adjacent tissue. In addition, apparently the endothelial cells themselves become somewhat sticky, so blood cells can stick to the surface and then proceed out through the openings between the endothelial cells. The fluid of the blood, that is the plasma, is the first thing to emigrate through the endothelial lining and into the tissue spaces. It is followed by the migration of white blood cells, which have stuck to the endothelial lining, and then preceded by amoeboid motion in between the small gaps in the endothelial cells. There has been much research concerning the mediators of this vasodilatation and the increased stickiness of the endothelial cells. It seems quite clear now that this is under the influence of some chemical mediators and not under the control of the nervous system. The denervated tissue still responds by vasodilatation following injury. Some of the chemical mediators are known, and these include such substances as histamine, serotonin, and bradykinin. These substances are apparently released from injured cells. Most of these substances are contained within small vacuoles within certain cells, mainly the mast cell, and when the cell is injured, it releases these enzymes. Predecessors of some of the other chemical mediators are released by injured cells, and then in contact with various tissue substances, they go through a complicated chain of reactions to form the final mediating chemical. The increased permeability of the small blood vessels allows the passage of blood fluid, that is plasma, through the endothelial lining and into the adjacent tissue space. As this fluid pours through the vessel wall and fills the tissue space, the tissue expands to accommodate this fluid, and the presence of plasma within the tissue spaces is known as edema. The process of the fluid moving through the vascular wall in the inflammatory reaction is known as exudation. Apparently, the function of the edematous exudate is to dilute any injurious agents which may be present within the tissue, and possibly to provide a medium for movement and a nutrient source for the cells that will soon follow. The stickiness of the endothelial cells allows the white blood cells to congregate along the inner surface of these cells, and then to move through the intercellular pores. The cells of the inflammatory reaction are shown on the chart in your manual. The neutrophil is one of the 3 cells produced in the granulocytic series of the bone marrow, and its function is primarily one of phagocytosis, that is, the trapping and engulfing of particulate matter. The small neutrophil functions primarily for the phagocytosis of bacteria. Once into the tissue spaces, the neutrophils seem to migrate toward the area of injury, and this process has been called chemotaxis. There is some question as to whether this truly occurs, but many people feel that in the area of injuries some chemical mediator is given off which attracts the neutrophils toward the injured tissue. In addition to phagocytosing small objects, such as bacteria, the neutrophils, when meeting up with an injurious agent of too large a size or too great a strength, release their proteolytic enzymes to lyse or dissolve dead cells, fibrin, and other debris. The presence of neutrophil with areas of liquefaction necrosis within viable tissue is known as an abscess, and the liquefied material is known as pus or suppuration. The presence of an acute inflammatory reaction can be affirmed by taking a white blood count from the peripheral blood of the patient and noticing that there is a leukocytosis or increase in the number of white blood cells. Again, the most characteristic white blood cell in the leukocytosis will be the neutrophil. Following the exudation of the neutrophils, other white blood cells will begin to leave the blood vessels, and these include the lymphocyte and the monocyte. The lymphocyte is apparently a mobile form of the lymphocytic series, and when it reaches the inflammatory reaction, it is capable of maturation into the plasma cell for the production of antibodies. Antibodies are proteins which are formed in response to substances secreted by the injurious agents, known as antigens, and the antibodies aid the inflammatory reaction in a number of ways. Some of the antibodies coat bacteria and allow the phagocytic cells to engulf them. These antibodies act by reversing the polarity of the bacterial coat. Other antibodies neutralize toxins secreted by microbiologic agents. Thus, the function of the lymphocyte is to mature into the plasma cell for the production of antibodies. Remember that the lymphocyte and the plasma cell are not formed in the bone marrow, but are formed in the lymph nodes and then carried to the area of injury by the bloodstream. The monocyte also immigrates from the blood vessels at about the same time and travels to the area of injury for the purpose of phagocytosis. The monocyte is much larger than the neutrophil, and thus it is sometimes known as the macrophage, or the phagocytizer of large objects. It is capable of phagocytizing bacteria that were too large for the neutrophil, and also of phagocytizing dead neutrophils and other tissue debris. If the material to be phagocytized is too large even for the macrophage, these cells can undergo amitotic division. That is, the nucleus divides and the cytoplasm enlarges, resulting in a multinucleated giant cell. These multinucleated giant cells are then capable of phagocytizing tissue that was too large for the macrophage. These multinucleated giant cells are frequently seen in foreign body reactions as well as in tuberculosis. Other cells that may be present in the inflammatory reaction include the eosinophils, which are part of the granulocytic series and are seen primarily in allergic inflammatory reactions and in parasitic infections. Basophils are also of the granulocytic series, and these are occasionally seen. The cardinal signs of acute inflammation have been known for many centuries, and the first 4 of these were stated by Celsius, a Roman nobleman. He said that an acute inflammatory reaction was red, hot, swollen, and painful. The redness results from the hyperemia due to vasodilatation. The heat is also due to the hyperemia in vasodilatation. The swelling is due to the edema, and the pain is probably due to a combination of the swelling and the release of the irritating chemical mediators at the site of the injury. Sometime later, Galen, a famous Greek physician, added a fifth cardinal sign, loss of function. When an inflammatory reaction occurs in an extremity, for example, it is often painful and discomforting to use this extremity, and thus this part of the body's function is lost until the inflammatory reaction subsides. In summary, the cardinal signs are again red, hot, swollen, painful, and loss of function. Naming an inflammatory reaction is done in a series of names joined together. First, it must be determined on the duration of the inflammatory reaction, and those of short duration are known as acute, those of long duration are known as chronic, and those of the in-between stage are called subacute. The second part of the name depends upon the type of exudate produced in the inflammatory reaction. If the inflammatory exudate consists primarily of red blood cells, it is known as a hemorrhagic exudate. If it consists of pus, it is called a suppurative inflammatory reaction. If it consists primarily of a thin liquid from the blood, it is known as a serous inflammation. It may be characterized by the presence of fibrin and is called a fibrinous exudate, or it may be characterized by the presence of mucus and is known as a catarrhal inflammation. The name of the organ or tissue is added next, and to the end of the name is added the suffix itis. Thus, the inflammatory reaction seen in a skin wound is called an acute fibrinous dermatitis. A bleeding ulcer of the stomach could be called a subacute hemorrhagic gastritis, and a common nose cold would be called a chronic catarrhal rhinitis. After the various inflammatory cells resolve the injurious agents present in the wound, including the microbiologic agent, fill the wound defect. This is the process of healing. Two types of cells predominate in this next stage of the inflammatory reaction, and both of these cells originate from primitive mesenchymal tissue. One of these cells is the fibroblast, which migrates into the area of the blood clot and deposits a framework of collagen and reticulum fibers. Another cell that begins to proliferate at the same time is the angioblast, which is the vessel-forming cell and the primitive precursor of the endothelial cell. Small buds from the capillaries, arterioles, and venules begin to project into the fibrous connective tissue deposited by the fibroblasts, and to lay down small blood vessels necessary for the support of this new tissue. This new, highly vascular and immature connective tissue is called granulation tissue, because when viewed grossly in the wound, it appears to be made up of a number of small granules. Following the deposition of granulation tissue into the wound defect, the proliferation of squamous epithelium across the granulation tissue begins. At the same time, the fibroblasts continue to lay down more collagen within the granulation tissue, and this tissue becomes progressively less cellular and more mature. This process is called repair, and the granulation tissue is gradually turned into mature scar tissue, surfaced by stratified squamous epithelium. Regeneration must be separated from repair. Repair generally means the replacement of a tissue by scar tissue, whereas regeneration means the replacement by the original tissue. In the skin wound, scar tissue is virtually the same as the subcutaneous tissue, but a wound to the central nervous system is replaced totally by scar. That is, there is no regeneration of the neural components, and a total loss of function in this area results. Thus, regeneration is basically the replacement of an injured tissue by a newly formed similar tissue from proliferating adjacent specialized cells. The more specialized the tissue, the less likely it is to regenerate. For example, the neurons of the central nervous system, as stated before, have virtually no power of regeneration. Also, some of the glandular tissues, for example, the glomeruli of the kidney, also do not regenerate well. The simpler or more primitive tissues of the body regenerate quite readily. This would include things like connective tissue, the blood-forming or hematopoietic tissue, bone, and the liver. Inflammation is an extremely important process, and it will be present in almost every patient that you see in your professional career. Remember the cardinal signs of inflammation, and you should be able to observe them quite readily in the gingiva of most patients. Remember also the step-by-step process of healing and what you can do to facilitate this process. Stop the cassette. Complete the remaining items in your manual. This concludes lesson number 2.